Good afternoon. The topic is Geneto urinary fistulae. Fistula is an abnormal or surgically made passage between a hollow or tubular organ and the body surface, or between two hollow or tubular organs. It can be result from congenital anomalies, malignancy, inflammation, infection, radiation therapy, iatrogenic, external tissue trauma, ischemia, parturition. So some types of urinary fistulae heal with conservative management. Surgery is usually necessary for a definite repair. The types of fistulae are from the bladder: vesicovaginal fistulae, vesicouterine fistulae, vesico-urethrovaginal fistulae; from the ureter, uretrovaginal, uretrouterine, uretrocervical fistulae; from the urethra, urethrovaginal. From the vesicovaginal fistula is the most common occurred fistula known since ancient times. The etiology of vesicovaginal fistula: the traumatic, radiation therapy, advanced pelvic malignancy, infection, foreign body, obstetric cause, obstructed labor, forceps dilatation, uterine rupture, cesarean LSES, and congenital. The risk factors for iatrogenic injury: inadvertent accidental injury to bladder, operating without bladder catheterization, performing emergency setting, prior uterine surgery, endometriosis, extensive infection, diabetes, arteriosclerosis. Prevention of vesicovaginal fistula. The persistent presentation of the vesicovaginal fistula is a persistent continuous leakage of urine from vagina, may or may not void normally. Iatrogenic fistula post transabdominal hysterectomy present immediately after polyps removal. Radiation therapy related VVF may take months to present. Post urinoma formation, patient may develop ileus, hematuria, and bladder irritability. The physical examination and specular examination. In the picture, you can able to see the fistula, pervaginal examination, fistula. Examination in this upper picture, I can able to see the fistula with the ureteric catheter through the fistula near the left ureteric orifice. The lower picture is the large vesicovaginal fistula. You can able to see the vagina through the cystoscopy, large fistula. Then radiological imaging, voiding cystourethrogram, especially with the voiding phase. You can be able to see the center picture. You can able to see the contrast in the vagina. In the oblique film, there is a contrast in the vagina. In this right side picture, the fistulous connection between bladder and vagina. The classification system, there is a Waldiak classification system and WHO classification system are there. Regarding the timing of surgery, there is no consensus for early repair. In obstetric VVF, 3 to 6 months delayed to allow maximum demarcation of the ischemic tissue and the resolution of the associated edema and the inflammatory reaction. In radiation-induced VVF, the time delay is 6 to 12 months delay. For small fistulae, vaginal approach can be attempted as soon as 2 to 3 weeks after the initial injury. If conservative therapy fails, that is, the patient remains wet when a Foley catheter is in place to provide adequate drainage of the bladder, and the patient is in a good general health. Approach, abdominal approach and transvaginal approach are there. And the principles of the surgery: excision of the fistula tract is not always necessary and may even compromise the repair in some patients. If the VV is adjacent to the ureter, then excision of the tract may mandate reimplantation of the ureter. Tissue interposition flaps are used in the setting of irradiated tissues and obstetric fistulae, failed prior repairs, large fistulae, and patients with tenacious repair. In this picture, the vaginal flap splitting technique. That first picture A, there is a retraction with the retractor. The B, the second film, this anterior vaginal flap. Third picture, posterior vaginal flap. Then closure of the perivesical bladder in the interior. Next, in a transverse layer, and next layer in the vagina, vertical flap. Then closure of the flap. In the tissue interposition, Marsh's flap is commonly used for urethrovaginal fistula. This picture showing the Marsh's flap with the pedicle inferiorly. The pedicle is from lower aspect with vertical labial incision, vertical incision. In abdominal techniques, preferred approach in those cases requiring augmentation, cystoscopy or urethral reimplantation, used mainly in supratrigonal fistulae. Suprapubic interperitoneal approach is called low corners approach. It is an extraperitoneal approach. Other methods, open, laparoscopic, robotic, through robotic can able to do. This suprapubic O'Connor's approach. There is a bladder open bivalve down to the level of VVF. In the second picture, the VVF tract is excised. In third picture, closure of vagina. Then bladder is closed in multiple layers. Then interposition of the momentum between bladder and vaginal closures. The omental flap harvesting is based commonly from left gastroepiploic artery. If a large length is required, right gastroepiploic is divided and brought down to pelvis. Other tissue interposition, graceless myocutaneous flap, rectus abdominis flap, bladder mucosal flap. Next, the ureterovaginal fistulae. The mechanism of injury resulting in iatrogenic postoperative ureterovaginal fistula includes ureteral laceration or transection, blunt avulsion, crust injury, partial or complete suture ligation. And overall, the ureter is most commonly injured during gynecological surgery in the distal 1/3 or pelvic portion, which is accordingly the only location at which the ureteral injury may result in ureterovaginal fistula. In this picture, the position of the uterine artery, which lies in front of the urethra. It is called water under the bridge. The water is urine in the ureter. The bridge is the uterine artery. The uterine artery lies anterior to ureter. Then the investigations, the intravenous urogram, you are able to see the dilated ureter, left ureter with the fistulous communication. In management algorithm, exclude VVF cystoscopically and confirm diagnosis with IVU. First attempt can be done by stent placement. It's unsuccessful surgical repair, ureteroneocystostomy. If it is successful placement, remove stent in 4 to 6 weeks. Repeat imaging, persistent fistula requires surgical repair by ureteroneocystostomy. Then next is the vesicouterine fistula, most common post-cesarean section. Anatomically, the most common location of the fistula is along the posterior bladder wall in the midline or from the genital side, just parallel to the internal cervical os. Urinary incontinence is uncommon because of the sphincter-like activity of the cervix. The exception is in the setting of an incompetent cervix wherein urinary leakage is constant. The Yusuf syndrome is a triad of vesicouterine fistula, semenonuria, cyclic hematuria with maintained continence, apparent amenorrhea with secondary infertility. Diagnosed cystoscopy, able to see the fistula in between uterus and bladder. In the cystogram, the contrast in the vagina is there. Then the next fistula is the ureterovaginal fistulae. Causes most common in obstructed labor, post-genital reconstruction, post-sling surgeries for stress urinary incontinence, trauma by pelvic fracture, vaginal neoplasms. Here, voiding film, you can able to see the fistula in between urethra and bladder. Again, contrast in the vagina. This is cystoscopic findings. Able to see the fistula from the urethra to the vagina. Management is a vaginal approach. There is an inverted U-shaped incision, and then anterior vaginal wall flap is mobilized. then the epithelialization margins of the visual tract is reapproximated with observable sutures for the initial layer of closure. Then periurethral fascia may be closed as a second layer. Then uroenteric fistulae, colovesical fistula are common in diverticulitis. Ileovesical fistula are common in Crohn's disease. Most common presenting symptom is pneumaturia. Other urinary tract fistulae are rectourethral fistula, pyelovesical fistula, uretrovascular and renovascular fistulae. Thank you.